So this patient has a very deep set eye, and really it's deep set because the brow is elevated. Down here she's not so deep set, so we're going to tilt her head down. So let's do that. So into a Trendelenburg position we go. Good. Now just take the table up a little bit. So this will dramatically improve the access of my left hand instrument to the eyeball. And I think some people are afraid to go Trendelenburg because they think, gee whiz, increasing intraocular pressure or vascular pressure or whatever. I've done it so many times and I've just never had a problem doing it. And I think that the problem of poor access and difficulties like that really outweighs it. So you really want exposure. Get the eye exposed. That way you see what you're doing better. Much more important than any concerns. I've never had a problem because of increased vascular pressure in an eyeball with tilting the head. Okay, so our plan here is to remove the cataract and put in a toric IOL in this patient. And this lady, as you can see, doesn't dilate terribly well. I'm marking her axis, which is 82 degrees or so. And then, you know, in men, when you see pupils that don't dilate well, your mind immediately goes to Flomax and similar drugs. In ladies, you think, well, it could be some of the antihypertensives, but there's another whole class of medications that decrease pupillary dilation. You just saw me make the incisions there, and I'm now going to put some lidocaine in the anterior chamber. And that is the psychotropic medications, amitriptyline, those kind of drugs. They have a smooth muscle relaxant effect that's very similar to the Flomax type of drugs. I've seen it over and over again. So anyway, I'm using Viscoat as my chemical pupil dilator, or at least chemical hold the pupil where it is medication. Irrigate nasal to temporal, please. We irrigate nasal to temporal when we have particles we want to get rid of on the surface. So now we'll go ahead and do our rhexis, and we'll of course watch to see what the pupil does during the case. The patient has a bit of a restless leg syndrome, and that's what you're seeing right now.
It's arthritis.
Yeah, she told us she has some arthritis. So there's our rhexis. I just followed the curve of the pupil to get that rhexis, which is, I'm going to tell you, it's around a 4.5 or 6 rhexis. Now we'll see, usually when the pupil shallows, as you do hydrodissection, which is what I'm doing with this flat 23 gauge cannula, when the chamber shallows, the pupil comes down. And there it is. Yeah, a little mechanical effect there. So then we do viscodissection for 180 degrees under the anterior capsule. And while we're in there with the visco cannula, we'll re-enlarge the pupil. And from time to time, I think we're going to see her leg move, and you won't know that except that you'll see the globe appear to be moving slightly. So this is the balance tip of the Centurion. I'm setting the sleeve for maximum infusion. And here we have the chopper, position 1 on foot pedal, and pop in, and we're ready to go. Now I want to stay in the middle here. If I go out by the edge of the iris, what's cornea, please? There are 2 problems with doing that. One is I might attract it. Probably wouldn't. But 2, I'll remove the viscoat that's there. And then my invisible pupil dilator, chondroitin sulfate product, is gone. And then my pupil gets smaller. So I'm zooming and focusing on the deeper layers of the nucleus here. Now that I have a red, and it's a pretty dense nucleus. Now that I have a red reflex down there, I think I can chop. So let's do that. Now I'm going to, there's a viscode aqueous mix here, and that's decreasing my acuity. So let's go to quadrant. And I'm just going to remove some of the viscode from the center of the chamber. Now back to sculpt and wet the cornea. Okay, so now I can see better, and I'm going to do a chop over here, and then I'm going to remove that nuclear segment that I created. So again, the concept of decreasing quadrant, decreasing the contents of the capsule and decompressing it, if you will. And again, wet the cornea. Remember the deep set issue here? Well, that's not a problem now. She's way Trendelenburg position. Okay, I'm going to go to sculpt, and I'm going to impale and chop. And now I'm going to go to quadrant removal. Now another thing's coming into play here, and that is epi in the infusion bottle. And that may help to maintain dilation here. Of course, it takes a couple minutes for it to get in there and do its work. Wet the cornea. There's another thing I want to point out to you here, and that is the cornea dries out fairly frequently. When you see that intraoperatively, think that they may do that postoperatively. In other words, it may be a compensated dry eye syndrome. So that's the kind of case you might want to put on a lubricant, maybe 4 times a day, maybe after their steroid drop or whatever, their antibiotic drop. See how the cornea is dried out again? Wet the cornea? Good. So that's what we will do here. So sometimes you can head trouble off at the pass simply by what you observe intraoperatively. And this is the 90-degree INA tip. And small port, 0.25. Not a lot of cortex here. Subincisional. I like to protect the posterior capsule when I go subincisional. See how the spatula is posterior to the phaco tip there? I'm sorry, to the INA tip there. So there's no way the posterior capsule is getting to my port there. And you know, the data is that more PC openings occur during cortex removal than during phaco. But I think the combination of a 90-degree INA tip and protecting the posterior capsule dramatically reduces chances of opening a PC during cortex removal. I have to tell you honestly, I don't remember the last time I opened the posterior capsule during cortex removal. It has to be more than a decade. So now we're going to inject our toric IOL, fixating the globe, a little cranking back and forth there with the tip to seat it into the incision. Then I press away from me and down, and that keeps it seated in the incision as I inject the IOL. And once it clears the tip of the cartridge, I just use the spatula to depress it. Before it opens fully, I'll rotate it to nearly the final resting position that I want it to be in. You see the epithelium there, a little dryness again. And now we'll remove the OVD from behind and then in front of the IOL before we put it in its final position. The best way that I've found reliably to rotate a toric is simply to put the tip of a spatula at the haptic optic junction. Now you can see what I'm doing is I'm rotating the eye from one side to the other to look in and see that the marks on the toric are aligned properly, and they are. So now we're ready to just do some stromal hydration. Now, if you look carefully, you can see the posterior capsule has some small areas of fibrosis, whatever. Those aren't visually significant. And I wouldn't spend time and run fluid through an eye and vacuum them and that kind of stuff. That's not going to affect your acuity one whit. And I'm just irrigating the angle as I now do this to get OVD out of the angle and reduce the chances of a pressure spike. And then the last thing here is I'm going to inject the vancomycin into the anterior chamber. Can you look down a little? Good. And we're finished.